Namaste everyone and welcome. So, today we're going on a little tour. A tour of a place we use literally every minute of the day, but probably don't think about much, the oral cavity. Trust me, it's a whole world in there, full of fascinating and sometimes dangerous things. So let's get ready to explore it together.
So, what's on the menu for today? We'll start with the mouth's own little ecosystem. Then, we'll look at what happens when tissues get a bit overexcited. We'll cover some unwanted guests, viruses and fungi, and then the really important part, the red and white flags that you absolutely cannot miss. Finally, we'll tackle oral cancer itself. Chalo, let's get started.
Okay, let's dive right in. Look, before we can talk about all the diseases, we first have to understand the baseline, right? What does a normal mouth even look like? And let me tell you, it's not some quiet, sterile place. No. It's more like a busy city, a real metropolis teeming with life.
Just look at that. More than 2,000. Can you believe that? That's how many different kinds of microbes, bacteria, fungi, you name it, are living in your mouth right now. It's a massive, complex ecosystem, and usually everyone lives in harmony. But when that balance is disturbed, that's when we pathologists get interested.
So what's the first sign that this ecosystem is out of whack? It's this, gingivitis. I guarantee you will see this every single day in your clinic. It's just inflammation of the gums from plaque buildup. Simple. And the best part, the key message for your patients, is that it's 100% reversible. Just tell them, brush better, floss better, and this goes away.
Okay, now listen very carefully. This is a Viva question for sure. What's the difference between gingivitis and periodontitis? Think of it this way, Beta. Gingivitis is like a smoke alarm going off. It's a warning. But periodontitis, that's the house actually being on fire. The inflammation has gone deep. It's not just the gums anymore. It's attacking the ligaments, the bone, the very things that hold the teeth in place. And here's the scary part. Once that support is destroyed, it doesn't come back. It's irreversible. That's how people lose their teeth. All right, moving on. Let's talk about what happens when the tissues in the mouth get a little, well, reactive. They get irritated and decide to grow. You're going to see these lumps and bumps all the time in the OPD, so you need to know them like the back of your hand. All right, this one, everyone has had this, isn't it? The good old canker sore. In medical terms, we call it an aphthous ulcer. So painful. And look at how common it is. Almost half the population gets them. It's funny, for something so common, we still aren't exactly sure what causes it.
Okay, look at this. This is a classic case of the body saying, hey, stop that. You know someone who always bites their cheek in the same spot? Or maybe their denture is rubbing. Well, the body gets tired of the constant irritation, so it builds up a little protective callus, a smooth lump of fibrous tissue. That's it. That's an irritation fibroma, just a reaction to trauma.
Now, a patient comes to you with this, and they are going to be terrified. Why? Because it looks angry. It's bright red, it grows fast, and it bleeds if you so much as look at it. But you will be calm. You'll know this is a pyogenic granuloma. It's not cancer. It's just a crazy overgrowth of blood vessels, almost like healing tissue gone wild. And a classic place to see it? In pregnant ladies. We even call it the pregnancy tumor, though it's not a real tumor.
Okay, so we've seen how tissues react. Now let's talk about what happens when things from the outside decide to move in. Some very unwelcome guests. I'm talking about viruses and fungi.
And the most famous of these guests is, of course, herpes simplex virus type 1. Here's the story. You get it as a kid, usually. You might not even know. But then the virus does something very clever. It doesn't leave. It travels up your nerves and goes to sleep, hibernating in the nerve ganglia. And then, years later, you get stressed for an exam, you get a fever, you go out in the sun, and bam, the virus wakes up and you get that classic cold sore.
Right. This is a crucial clinical skill. You see a patient with a white patch in their mouth. What is the very first thing you do? You take a tongue depressor and gently try to scrape it. If that white stuff comes off, leaving a raw red surface behind, you are almost certainly looking at oral candidiasis, thrush. And here's why it's so important. It's a huge clue that your patient's immune system might be compromised.
Okay, everybody, I need your full attention now. Everything we've talked about so far is important, but this is life and death. Learning to spot these red and white warning flags in the mouth is one of the most vital skills you will ever learn. Get this right, and you will save lives. It's that simple.
So let's start with the white flag. The WHO defines leukoplakia like this: a white patch that cannot be scraped off. See, that's the first test. We just talked about thrush, which you can scrape off. This, you can't. It's stuck. And it's not any other known disease. It's a diagnosis of exclusion. And our default position? We have to assume it's dangerous until proven otherwise.
And here's what one might look like. It looks like nothing, right? So innocent, nah, just a little white spot. But this is why pathology is so important, because looks can be incredibly deceiving. A significant number of these, maybe up to 1 in 4, are already on the path to becoming cancer. So what's our rule? The golden rule: every single leukoplakia is precancerous until you have a biopsy report in your hand that says it's not.
But if you see this, a red patch, an erythroplakia, your alarm bells shouldn't just ring, they should be screaming. The white patch is a warning. The red patch is a 5-alarm fire. It is so much more sinister. The statistics are terrifying. When we put these under the microscope, the vast majority are either severely precancerous or have already turned into an invasive carcinoma. Red is much, much worse than white. And all of this, the red patches, the white patches, they're often the prelude to this, the main villain of the story: squamous cell carcinoma. It's the big one, the most common cancer we see in the mouth. But what's fascinating, and what has changed so much recently, is that this one villain now has 2 completely different faces, 2 different stories of how it comes to be. So here are the 2 pathways. For as long as I've been a doctor, the story was always the same. Oral cancer was a disease of old uncles who chewed tobacco and drank heavily. That's the classic pathway. But that's not the whole story anymore. A new pathway has emerged, and it's completely different. It's driven by a virus, the human papillomavirus, HPV. This is the modern pathway, and it's changing everything.
Okay, this table, this is a 5-star, must-know slide. For your exams, for your practice, for life. You have to know this. Just look at the differences. The HPV-related cancer, it's in younger people, often in the back of the throat, and, believe it or not, the prognosis is actually much better. The classic non-HPV cancer, that's our old uncle with the tobacco. He's older, the cancer is in the front of the mouth, and sadly, the prognosis is much worse. They really are like 2 completely different diseases that just happen to look similar.
And this slide is pathology in a nutshell. This is what we do. On the left, that's the gross. That's what you see in the patient's mouth, an ugly-looking ulcer. On the right, that's the micro. That's what I see down the microscope. You see those purple nests of angry-looking cells breaking through the basement membrane and invading? That is cancer. We connect the clinical picture to the cellular picture. That's how a diagnosis is made. And just to put it all in perspective, remember this one number: 95%. That's it. When a surgeon says head and neck cancer, this is what they mean 95% of the time. It is the king of cancers in this area. So, head and neck cancer equals squamous cell carcinoma. That should be an automatic reflex for you. So, I want to leave you with a final thought. The landscape of this disease is shifting right under our feet. The causes are changing, the patients are changing, and this means we have to change too. Our approach to preventing it, to finding it, to treating it, it all has to evolve. So the real question, which I leave for you, the future of medicine, to answer is, are we ready for what's coming? Think about it. Thank you.
All right, students, welcome back to our session. Today, we are going to dive deep into a very important, very intricate topic: the pathology of the head and neck. So let's get started. You know, in your clinical practice, you will see patients with all sorts of complaints. Someone will come with a simple nosebleed, another with a hoarse voice, or a small lump in the neck. To a common person, these might seem like small, unrelated issues. But for us as doctors, these are clues. These are stories that our tissues are trying to tell us. So today, we are going to learn how to read those stories.
So let us begin our journey right at the top, in the upper airways, the nose and the nasopharynx. Think of it like a busy traffic junction of the body, a prime location for all kinds of pathologies to develop.
Now, before we look at any specific slides, we must first understand a very crucial concept. It's a pattern. We call it small, round blue cell tumors. When you are looking down that microscope and you see a whole field of cells that are small, round, and dark blue, a specific list of diagnoses, a differential, should immediately pop into your head. This is fundamental pattern recognition in pathology. Here we have a perfect example. Have a look. This is an olfactory neuroblastoma. You can clearly see the small, uniform blue cells, right? But the real clue, the secret, is in the pinkish material that is sitting between them. That is the fibrillary matrix. And that's a huge clue that tells you this tumor has a neuroendocrine origin, coming from the olfactory cells right at the roof of your nose. Okay, moving on to another very important tumor, nasopharyngeal carcinoma. On the left side, you see the large, ugly-looking malignant cells, but the real story, the smoking gun, is on the right. That dark brown staining you see? That is a special stain, an immunohistochemistry, which is showing us the Epstein-Barr virus, or EBV, hiding inside the tumor cells. This connection between the virus and the cancer is a major etiological factor. You must remember this.
All right, from the upper airways, we will now descend a little bit, down to the larynx, our voice box, this beautiful, intricate organ that gives us the power of speech. But what happens when things go wrong here?
First, let's get our bearings. Let's orient ourselves with this diagram of the vocal cords. Look, on one side, you can see a small, smooth little bump. That is a benign singer's nodule. But on the other side, you see that ugly, irregular, nasty-looking growth? That, my friends, is a carcinoma. The difference is so stark, isn't it?
And here is the absolutely crucial difference. One is just a benign reaction to overuse, like a callus you get on your hand from writing too much. The other, the carcinoma, is a true malignancy. And what is the primary cause? What is the villain here? Tobacco smoke. One is just a mechanical problem. The other, it's a complete cellular catastrophe.
And here is the grim reality of it. This is a gross specimen, a larynx that has been surgically removed. Just look at that massive, ulcerated, fungating mass. This is the devastating consequence, the price paid for long-term exposure to the carcinogens in smoke. Let's move laterally now, from the center, to the sides, to the ear. Now, while ear problems may not always be life-threatening, they can have a huge, huge impact on a person's quality of life. Our hearing is so precious. Now, please pay close attention here. This is a very common point of confusion for students. Cholesteatoma. It has oma in the name, but it is not a tumor. I repeat, it is not a neoplasm. It's actually a non-neoplastic cyst, which is filled with keratin. But, and this is a very important but, it acts badly. It is locally destructive, and it can erode all the delicate little bones of the middle ear. It's a very serious complication of chronic ear infections. This brings us to a very common clinical problem, a patient presenting with a lump in the neck. Here, a systematic approach is absolutely key. Let's discuss one very important tumor that you should be able to recognize. Have a look at this beautiful slide. This is a paraganglioma. Do you see how the cells are arranged in these little clusters or nests? This classic textbook pattern has a German name, and it is essential for you to know it. It is called Zellballen. And don't get intimidated by the German word. Zellballen simply means cell balls. That's it. Cell for cell, ballen for balls. You see? Pathology is not so difficult after all. These small balls of cells, nicely separated by blood vessels, that is the hallmark of a paraganglioma. So, recognizing the pattern is step one. But we are scientists. We need to confirm our diagnosis, right? And for that, we have our special stains. This is immunohistochemistry. The dark brown color you are seeing here is positive for a marker called chromogranin. This confirms the neuroendocrine nature of our cell balls. And with that, diagnosis confirmed. Our grand tour now takes us to the salivary glands. You might think they're simple, just producing saliva, but let me tell you, they are a hotbed, a real world of diverse and sometimes surprising tumors. Just how diverse, you ask? Well, there are over 30 distinct types. That's right, more than 30. It is practically a subspecialty of its own. But please, don't worry. We will focus only on the most common and the most clinically important ones. So, to simplify this very complex topic, here is the high-yield information you absolutely need to know. The most common benign tumor is the pleomorphic adenoma, and the most common malignant tumor is the mucoepidermoid carcinoma. And for both of them, the most common location is the largest salivary gland, the parotid gland. Simple. Now let's see what the most common benign one looks like. This is a pleomorphic adenoma. You can see it is well circumscribed, and notice the cut surface. It has so many different colors and textures. Some parts are gray-white, some are bluish like cartilage. This varied or pleomorphic appearance is exactly why it used to be called a mixed tumor. And here is its malignant cousin, the mucoepidermoid carcinoma. The name itself tells you the entire story. If you look at the slide, you can see the muco part, those clear, bubbly, mucus-producing cells, and then you see the epidermoid part, the solid sheets of pink, squamous-looking cells. It's a mixture of the two. It's all in the name.
Now let's just discuss one last tumor, a particularly nasty one, adenoid cystic carcinoma. I often call it the quiet invader because of its very sneaky and dangerous behavior.
And this slide, this one image perfectly shows you its defining characteristic. Look very closely. That structure in the middle is a nerve bundle. And can you see how the tumor cells are wrapping completely around it, invading that nerve space? This is called paraneural invasion. And this single feature explains why this tumor is so notorious for causing pain, why it's so difficult for surgeons to remove completely, and why it often comes back even years later.
So let us quickly recap the key take-home messages from today. 1. Viruses, like EBV, can cause cancer. 2. Our lifestyle choices, especially smoking, have very real, very devastating consequences on our cells. 3. The long, complex names in pathology are not there to scare you. They are actually descriptive. They tell you what you're looking at. And 4. The microscope is like a crystal ball. Histology can reveal a tumor's future behavior.
We have explored this microscopic world where cells can rebel and go wrong. But I want you to always remember, behind every single slide, behind every diagnosis, there is a patient, a human being with a story. So as you go forward in your careers, my question to you is this: how will you use this microscopic knowledge not just to treat a disease, but to truly listen to your patient's story? Thank you for your attention.